fractured his little femur. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So our approach is going to be basically from the greater trochanter down to the patella, maybe cheating a little bit cranially because the demarcation between the biceps femoris and the fascia lata is a little bit cranial to the axis of the femur. So we're making this lateral approach, and so we will go cranial to the biceps muscle, basically through the demarcation between the biceps muscle and the tensor fascia lata, or sorry, the fascia lata. Got a bit of bruising here. So it's a midshaft diaphyseal fracture. It's basically transverse. Got a few different ways that we can fix this, but one way is clearly superior to most other ways, and it's going to be to put a locking plate on it. Now I may decide to do an intramedullary pin as well, which would be to just help me align the fracture prior to placement of the plate. I'll just have to see how easily it comes together. So that's a little cut through the fascia lata. And that first muscle that we can see deep to the fascia lata is the vastus lateralis. Alright, and then we'll get a Gelpi retractor in there. Now caudal to the femur is an important structure with a short name that we need to watch out for, and that's the sciatic nerve. So putting retractors back here, we just have to be careful that we don't inadvertently skewer the sciatic nerve. I'm coming all the way down basically to my patella, to my stifle. We're getting some seroma here. I don't think that that's actually active bleeding. Trying not to stick my fingers in there too much, but we don't have much of a choice. I guess we've got a choice, but it certainly makes it a lot easier. So that's the greater trochanter up there. So greater trochanter there, stifle down there. If I am going to put in an intramedullary pin, I will definitely expose the stifle. So I want to see if my pin is penetrating the articular surface. Can I get a bone clamp? Do we have a yeah, or a ratcheted reduction forceps? Let me see what we've got. So there's my femur there. I'll use a freer elevator. Clean that up. A little bit of a fissure. Right there. So the big concern with that is that if I reduce this fracture, I could split that fissure off inadvertently. And to protect that fissure, I can put a cerclage wire on, but just have to see if the cerclage wire is going to really get in the way of my plating the fracture. I think I will put a cerclage wire on. Can I get some, maybe 21 gauge cerclage wire and a wire kit, cerclage kit? I beg your pardon?
21 gauge wire.
Yep.
Okay.
I'm going to put that cerclage wire on to just protect the bone from splitting out when I go to reduce the fracture. Let me see what that 21 looks like. Maybe 20? Yeah. Sorry about that. Thank you. So just waiting for our cerclage wire. Do we have a little pin cutter or a little wire cutter?
You're opening one.
Great, thank you.
We want something smaller than that. Yes.
I want a bigger, just bigger than that
This
20.
is the second after that.
That's quite big.
Quite big. And this is the smaller one.
You don't have one just bigger than that? All right, so I'll try that one. So I'm using 21 gauge. Probably 20 might be a little more appropriate, but it's the next size up that we have here. It looks like it's 19, which is quite big. It's very bright red. So we'll just go around the end of that. And I always twist my wires clockwise because that way if I ever have to remove wires that I put in, even if I can't see them very well, or I don't have good visualization, I'll know that I had put them in clockwise. Okay, go ahead and cut that off with about 4 twists left. Yep. Open, close. Yep. All right, so that's the cerclage wire that I've put in there to protect. Now we will take a bone clamp here. Grabbing onto that proximal segment maybe. All right, and then we get it freer. And that proximal segment is quite long down here. And so what that tells me is that we've got a lot of contraction of the muscle, which is going to make it a little bit tricky to get it reduced. And when we do get it reduced, it's going to be under some pressure. And so it's possible that you could split out bone fragments or something like that. So I'm just looking carefully to see if there are any fissures here. Can I please see a 9-hole 2-4 plate, or do you have them all in one box? 2.4.
We have 16 holes. This be okay?
I'll just have to cut it. Let me see a 2.7 plate.
2.7. This is the 2.7.
Back to the 2.4. Back to the leg. I think that the 2.4 is what we want.
Okay.
And so I'll just have to cut that. All right, so now what I have to do is I have to reduce that fracture. The other thing to consider is that by putting in the Gelpi retractors, it is going to inhibit or interfere with reduction because it's causing relative shortening of the surrounding muscles. Twist. So that looks pretty good. Take out that top. Can I please get those little Gelpies that we had before? you. Might be able to just be a little bit more specific with my retraction so that I can take out this big gulpy. So I'm pretty happy with that reduction. I think it'll get better as I put the plate on. Alright, so we'll look at this plate. So I'll take the pin up. Just grab onto that plate for me, please. Ready?
Yep.
Okay, great. So I've cut my plate down. Now the difference between dogs and cats is that the femur is perfectly straight in cats and it's a little bit bent in dogs. Alright, so what I'm going to do is I'll align it with the proximal segment. First. And then I'll align it with the distal segment. So let's see if I can get a bone clamp on here. Do we have the screw kit? Yes, please. My patella is down here. Do we have saline?
Yep.
So I need a 1/8 drill bit.
Yep.
Hopefully sharp.
This is a 1/8.
Thank you.
And this is the size. You can check the table is monitor. So if we need to add up to our measurement. You have the table there? If we need to add to our measurement. The depth gauge and this case. Can you check the table? With the depth gauge here.
Waiting for depth gauge. Thank you. So we need to add about 4 to each one.
Run off to the nearest.
We're sure that's at 2.4.
2.4 kit, right? With the medium.
With the small depth.
With the small. This is the small depth.
Yes, the small depth.
Run off to the nearest.
Nearest medium.
So take a 16, please. 16 locking 2.4. That's right. So just, these are special, they look like hemostats, but they're actually special bone holding forceps. Somebody had made a comment that I'm using hemostats. trying to get this plate compressed onto the bone. That looks great there. Drill guide, please. Do we? I'll try this one again. This one is a bit dull, but. Take a 20, please. So there's a question, do I ever remove bone plates when there's evidence of healing? I usually don't unless they're causing a problem. Do we have the other screwdriver tip? Because this one broke off. Yeah. Grab that screwdriver. So that one should be able to come off now. Alright, so let's just have a look. Where's my Freer elevator, please? That looks pretty good. I'll take a 16, please. Now when I was training, we would have filled all the screw holes, but now we don't. We leave it a little bit so that there's a little bit more bend to it, or a little bit more instability, so we get a more rapid callus formation. Okay, so just having another look. That's really good. That felt a bit funny. Let's see what we've got here. Okay. Kind of on the leading edge of the bone. Yeah, that's cool. Just making sure it didn't exit the cortex. No, that's good.
It's okay.
14, please. Uh, 16, please. And there's a question about bone plates over IM pins. I definitely prefer bone plates over IM pins, especially when we've got a transverse fracture, so you have no rotational stability. IM pin is going to provide no rotational stability at all, so we really need that plate. If you only had IM pins, you could do an IM pin and like a type 1 external fixator, potentially even tied in. I'll take a 14, please. Thank you. I'll just go back through and make sure our screws are tight. And I will run it through a range of motion and check our alignment. So let's go ahead and, so range of motion is good. Alignment seems good. Just have one more look at the alignment of the bone. It's within about a 0.5 millimeter. I'm pretty happy with that. Go back through and tighten all of our screws. flesh. Get some 2O PDS, please. Yeah, can I see the underside of that plate, the rest of the plate, please? So that plate, see how it's scalloped on the underside of the plate? That means that we can leave screw holes empty, and it's not going to make a stress riser. So you can see that that's scalloped there. All right, so all we have to close here is just the fascia lata to the biceps femoris. Don't have to close any other muscle layer. Yep. And obviously, definitely no drain in this. Match some 3O PDS, please, around. Yep. I'm just doing a little sub-Q closure here. Hannah, you happy to do that sub-Q?
Yeah.
And then skins if you think you need it. And I'll come over and make sure that I haven't missed any comments or questions. I will not cast the leg at all, so I can show some pre- and post-operative graphs afterward. So there's a question about why I decided not to compress the fracture. The reason is that in order to compress it, we'd have to use a DCP plate, and we didn't have a 4.0 DCP plate. And I think that the benefit of having a locking plate over the compression you get from a DCP plate is superior. Plus, I'm not sure if we even had a 2.4 DCP plate. I did basically, the other thing is that when you compress a fracture, they've shown that within about 6 hours of the fracture repair that you've lost that compression at the fracture site. So I kind of feel like maybe compression is overrated a little bit, and so I'd rather just have a really rigid repair, especially in a young dog. This dog is a year old, and the plate that we use is a 2.4 locking. And so, yeah, just to reiterate, those are not mosquito forceps, those are bone clamps. Regarding the detail of the direction of the twist of the cerclage wires, probably wouldn't be a bad idea to say that I twisted clockwise, so that if I'm not the surgeon that goes in and removes the cerclage wire, that it would be easier for them to tell what was done. So I think that's a good idea. All right, so that's pretty much it. If you haven't already done so, please subscribe to our channel and make sure that you turn on notifications. There's a comment about irrigation with an antibiotic. I don't believe that you should irrigate with an antibiotic, because the antibiotic is going to be at a very high concentration and could probably impact wound healing. We do intravenous antibiotics at the time of induction, and then every 90 minutes after that. So I think that that's more than adequate. All right, go ahead and wrap this up. Thanks a lot for watching. We'll see you again next week.